Welcome back, guys. This is week 2, part 3. We're going to go over the venipuncture procedure. We went over the procedure and how we're going to do it in order on that handout that I gave you on Friday. So this is just going to go over some more of those parts that we maybe didn't talk about on Friday, go a little more in depth with a few things, and we're going to keep rolling. All right. So the venipuncture is the process of collecting or drawing blood from a vein, vein puncture. The first thing we're going to do is review and accession the test request. Accession means we're putting it in the computer, okay? We have manual requisitions, computer requisitions, barcode requisitions. Requisitions are a request, okay? Your job is to see that all the info that is required is present and complete, verify tests to be collected, the time and date of collection. There are some tests that need to be collected on certain days. There's some tests that you have to draw the blood, let it incubate in an incubator microbiology for 24 hours, and then send it in. But the test is only run on Mondays, Wednesdays, and Fridays, and Monday's a holiday, okay? So you need to make sure when you are adding that test, like to the patient record, like getting ready to print out the barcode, right? You're going off the form that the patient brought from their doctor. You're going to make sure that each of those tests, you know the requirements and you know what's going on, so that, if it's not the correct day for that specimen to be drawn, you're letting the patient know they're going to have to come back a different day. Or, there's a lot of tests like that out there, but you'll know that. Another thing, you won't have to know that off the top of your head, right? When you get into your facility, if they have special things like that, that's what your orientation is for. That's what shadowing, a preceptor, every place that you go should have time for that. And they're going to tell you those special tests and those things to look out for, okay? So you don't have to know that right away. You don't have to know that now. All you need to know is that when that time does come, you are picking and not that you're picking, but that you're aware of specimen requirements and aware of the patient having to come back and get things stuck, so you're getting it done the right way, okay? You want to identify any diet restrictions or special circumstances, and then accession and record the order received. So accession, again, is putting what happens when we enter something in the computer, it gives it an accession number. So what that does is basically that's a number that's going to track that test all the way through to the test results, okay? So if the doctor's looking up something or, looking for the results, we can go enter that accession number and find out what's going on with the specimen, okay? All right, this is a manual requisition. This is where human error comes into play. You have to make sure all of the information is transcribed and entered correctly. Transcribed is written on the paper. So you want to guess, since I'm zooming in, the area that has the most mistakes. This right here, all this top form. Typically, the most mistakes happen here. Do you want to know what I have to work with my staff on the most? Is when it comes to the date. Something as simple as the date. We often just can't remember to check for that. We're so busy checking about the technical part of things. And sometimes the thought process is, well, if I got the technical part, isn't that the most important? Well, no, it's all important. There's not one that's more important than the other. Okay? So making sure if the line is supposed to be filled out, if the information is needed, that it's filled out correctly and it is given on the requisition form accurately. It's entered accurately. Okay? This is what a computer generated label looks like. So these are the barcode labels that typically go on the tubes. We're going to talk more about what goes on a tube. It is very important to remember that you never, never, never pre-label your tubes. Why wouldn't you want to pre-label your tubes? Well, what if you put that label on that tube, and then once you started the venipuncture, maybe the tube didn't work, or you have to stick them again, and then you're going to have to reprint the label to go on the new tube that actually has the testable specimen in it, right? We never go ahead and put date and time. We don't do anything with that label until after the blood draw is complete. And then we always label our specimen at the bedside with the patient in the chair, like with the patient present, okay? Always label it with the patient present right there, okay? And never pre-label your tubes. We're going to talk about things that go on that label in just a minute. All right, we are going to approach, identify, and prepare our patient, okay? So you need to be organized. You need to look for signs containing patient information like do not resuscitate, no blood pressure or venipuncture in the right arm. You need to lock lightly on the door. We can ask visitors to step out. Sometimes patients don't feel like they have the right to do that because it's family, but they may want privacy. So be that advocate for the patient and just say, visitors, do you mind? Because even if you say, do you want them to stay? Is it okay if they stay? They're going to say yes, because that person's going to be like, well, why'd you say no? Okay. Or they could. So make sure you're your patient's advocate. Ask the visitors to step out. Now, if they say no, it's okay, they stay, all of that, that's fine. Okay. You need to identify yourself. You need to obtain consent for the procedure. I need to get some blood from you today. Is that okay? You need to put the patient at ease using comforting, calming statements, okay? You need to ask if they have any questions. When we verify our patient, we talked about the three-way ID, right? You need to verify the patient's name and date of birth. You need to check it with the ID bracelet. You need to notify nurses or office staff of any ID discrepancies. You need to search for missing identification. You cannot proceed if you have not correctly identified them. You need to wake up sleeping patients, and we need to be we need to be cautious of how we wake them up. We don't want to disturb them. We don't want to scare them. We also can ask a relative or nurse to identify a patient who is unconscious, young, mentally incompetent, or non-English speaking. Okay? So why are identification procedures so rigid? We talked about this the other day. You can kill a patient if you have the wrong patient ID. Misidentification happens way more than you think, and it is a preventable mistake. Okay? Asking the patient to state their name and date of birth is what we call active patient participation in the ID process. That's important to remember. Verbal confirmation of the name and date of birth, armband check, and written requisition or label is known as a three-way ID. That is a test question, okay? So when we prepare the patient, we're going to explain the procedure. We're going to explain it in terms that they can understand. Are we going to say, I'm going to use an ETS evacuated tube system with a multi-sample needle to withdraw a copious amount of blood? No, we're not going to do all that, okay? We're going to address patient inquiries. We're going to know our job so we can handle their questions or know where to point them, what direction to point them into. We're going to handle patient objections. We talked about that a little bit. We're going to handle difficult patients and address objects in patient's mouth. So this right here is just a technical question, okay? This is talking about gum and candy in the patient's mouth. It is said that they should not have it in there. I don't enforce this one completely, but like if they're have problems having their blood drawn, you can ask them to take it out because we don't want them to pass out with gum or candy in their mouth. Okay. Again, that's a little bit of a gray area because, to be honest, I don't address that with every single person. Okay. But that is the standard. Regardless of the difficulties involved, you must always determine that the patient understands what is about to take place and get permission before proceeding. This is a part of what we call informed consent. This is important. You must get consent. All right. So, what do you think a conflicting permission statement is? A conflicting permission statement is when someone you say, "Is it okay if I draw your blood today?" And they say, "Yes, but I'd rather not." They just gave you permission and then took it back. You cannot proceed. Okay? They put their arm out, which we call implied consent. You're going to see this again, okay? Implied consent is where they put their arm out without saying anything, and we're saying that they're implying consent, right? But then they pull their arm back like they're unsure. They gave you permission and took it back. You cannot proceed. You cannot proceed until you have clear permission to move forward, okay? And then, if you don't understand abbreviations on label and requisitions, how are you going to prepare your patient or explain anything? So that's saying, am I expecting or suggesting that you should know all of this going into your first patient? Absolutely not. But you do need to pay attention and you do need to take an active role in learning that as you go. And what I mean by that is every day when you go in and you get these same labels every single day, you see a CBC every day. You're asking CBC, it goes in the Preble tube. And then even if you don't know what that test is or remember, Google it, find out, figure out what in the definition of that test can you translate to terms a patient can understand. So, for example, the patient asks, "What is the doctor looking for? Why are they drawing my blood today?" You will get that question a lot, okay? And so you need to just glance and know what you're going to say before you get in there, right? So when you get in there, they're asking, we'll say they ask the patient, the doctor wants a CMP and a CBC. A CMP is a complete metabolic panel. That is a chemistry test. That is measuring their sugar, cholesterol, liver function, kidney function, all the things, right? Our overall health. And then the CBC is a complete blood count. That is all of our red blood cells, white blood cells, and platelets and what they look like, their size and shape. Okay, that's going to tell the doctor if they're having an infection, allergic reaction, internal bleeding. Okay, are we going to tell them that it is to check and see if they have internal bleeding? It is going to freak them out. No, we're not saying that. We are not going to lead them into a diagnosis. What we're going to say is, well, your doctor has ordered what they call a CMP, and that's just going to give us an overall view of how all your organs are working. Okay? Kidney function, liver function, that they do it in routine physicals. Okay? And you don't even have to say that. It's just, you say it just gives an overall view of what's going on in your body. Okay? All how the major organs are functioning. And then when it comes to the CBC, you can say the doctor is just looking to count how many red blood cells, white blood cells, and platelets you have, making sure that everything is normal, that you don't have anything going on. Okay? And you can tell them, it's going to tell us if you are anemic. Well, again, you don't, let me backtrack there. We're not going to lead them into diagnoses. Again, if they go a little bit more specific or want more specifics, since I've gotten caught up in this because I understand it from the lab point of view, and I know where the doctors are headed based on the combination of tests and what I see going on, okay? But that's not, again, you don't want to get caught up in those things with patients. So what you would rather say, what you should say would be, I'm not sure about what all you have going on, and I'm not qualified, that's above my pay grade to, put the pieces of the puzzle together, but this is what the doctor's ordered so that he can figure out next steps for you or no steps for you, depending on whatever you have going on. And you can just say, I don't know that part of it, so I wouldn't give you an accurate view. You know what I'm saying? And that's to the question of like, if they're getting into also asking you about like, well, what does that mean? And what is that looking for? Could it mean I have cancer? Those kind of questions, okay? We don't want to get into that. But we do want to be knowledgeable. We do want them to have confidence in us that we know what we're talking about, okay? All right, we want to verify diet restrictions and latex sensitivity. All right, so when it comes to latex precautions, you just always, a good rule of thumb is just making sure everything on your cart, your tray, is latex free. But there are things that we do use, like that Coban, that stretchy stuff that sticks to itself, that gets really tight, and we use with patients kind of like on blood thinners, that kind of thing. Those do have latex in it, so you can't use that on a patient with a latex allergy. And they do have that allergy precaution noted because there are things you can't just assume everything you're using is latex free. You need to make sure that it is stated by the manufacturer, okay? But and making sure if you do have something that is not latex free, you're not putting it next to or mixing it with a latex product or latex free products, or latex allergies can be pretty severe, so we just really want to be careful with that, okay? If the patient has eaten and you're told to proceed with specimen collection, it's important to write non-fasting on the requisition in the specimen label or put it in the computer. Most things are automated nowadays, and you can put notes in the computer. So this, it's really important when a patient tells you that they have not been fasting and they have a fasting test to do. Typically, this is like for routine physicals that you see this happening, and you will tell them, they need to come back. If they refuse to come back, you can draw the blood, or you can call their doctor and ask them what they want to do. Typically, you just draw the blood and say it's not fasting, because if you send that in without that note, if you just write it on the label, that is not always is not always added to the test information in the computer. And it's your job as a phlebotomist to make sure that it's not only noted on the label, but noted in the system so that the lab technician can carry that information on to the doctor, okay? Because, again, we talked about this the other day, with the non-fasting thing, if the doctor gets your results and it says that your cholesterol is like an outrageous number, and he puts you on cholesterol medicine, but fasting, and you had Krispy Kreme and coffee because you forgot that you need to be fasting or whatever it is, okay? And then you're getting, now you've got to go get your labs checked every 3 months for your liver function because of the medication, and it's just not fun, and it's not good health care, okay? So officially, if the patient has stated that they are not fasting, you should contact the nurse or medical assistant, the office staff that ordered the test, and let them tell you how to proceed. If you are told to go ahead, be sure to note that the patient was not fasting. This is so the lab personnel will not recollect the specimen if results are abnormal, indicating a non-fasting specimen. Also, the results just get pushed through too. Okay, that happens more than them getting redrawn. There are specific tests that get redrawn all the time because you just can't brush past it. But anyway, now officially, a lot of times what happens is we're not always making the call to the doctor, but we are not making, if that patient is just insisting that it be done, um, then even, despite if the doctor said come back or whatever, then again, that's where that noting that information in the computer is going to be most beneficial. Okay. All right. We're going to sanitize our hands always before and after gloves. Positioning our patient. Inpatients are going to be lying down in the bed, typically. Outpatients sitting up in a drawing chair. Patients who are prone to fainting, reclining chair, sofa, or bed. Support the hand or arm that's to be the site of the venipuncture. Now, I am a little bit old school and I draw blood wherever it is needed to be drawn. Okay, if the person is in the wheelchair and can't get out, or is difficult, or could be dangerous and potential for them to be hurt or harmed moving, we're going to stay right where we're at, right? We don't need to move, okay? I've drawn people off the back of the trunk of my car before when I was a traveling phlebotomist. So for book purposes, yes, that's typically where you're going to, how you're going to be drawing patients. But again, for me and most phlebotomists I know, we take each blood draw as a new challenge, and it's exciting, and we're going to do whatever we can to get the blood. Kind of like they say, whatever they can do to get the perfect shot. Like, it is fun to see what we can do, and good, it makes for good stories too. All right, when we apply our tourniquet, it's going to be applied at least 3 to 4 inches above the intended site. That is no matter where it is. Like if we're going down in the forearm or the hand, those places, it's just 3 to 4 inches above our intended site. We're never going to apply over an open sore. We can apply over washcloths or clothing on patients, like elderly patients with sensitive skin, and ask the patient to make a fist. We'll go more into the challenges of the tourniquet application when we talk about geriatric venipuncture, okay? Now, the tourniquet is supposed to, it's not supposed to stay on longer than 1 minute officially, because it can cause hemoconcentration, and a lot of other problems, okay? So we do not want to leave it on for over a minute, okay? But that does not mean that you need to rush and take it off. There are some that say pop the tourniquet as soon as you see blood. I'm telling you, you do that, you're not going to have, it's not going to go, you might have to redraw the patient depending on how many tubes you get, okay? I do not suggest that. And we're going to practice in the lab just how long 1 minute is, okay? Actually, I just want you to pause the video in just a second, and I want you to just put your timer on your phone and sit quietly for 1 minute, but don't close your eyes. I want you to look around and just see how long. I mean, 1 minute is longer than you think. So y'all do that right now, okay? So how did that go? How did it feel? To me, it always feels longer than I realized, okay? So we're going to get more into that and talk about that more, especially when we're actually doing the venipunctures with each other, okay? Um, so a tourniquet has a greater tendency to roll or twist on arms of people who are larger, okay? And we call the tourniquets that are for those people bariatric tourniquets. Those are typically not available. Um, Two tourniquets placed on top of each other will sometimes be sturdy enough to prevent the problem. And I will show you what that looks like in the lab, okay? So, our preferred site is the intercubital area of the arm. Um, there's a whole video that I want you guys to watch on vein selection, and that's going to go deep into what are our choices and in what order we draw from. Okay, when we palpate is to touch. When we touch, we are looking for the bounce, right? And we'll roll our fingers side to side while pressing to vein to judge the size. I always recommend doing it. I inspect the area first. I choose where I'm going to start palpating, close my eyes and start palpating. Kind of palpate from the middle out, okay? And I'm also, with my eyes closed, I'm visualizing what that vein looks like under the skin and how it runs. So that when I put that needle in, if I need to adjust, I've got that map in my mind of that vein and where I'm headed, okay? So to avoid veins that feel hard or cord-like or lack resilience, and then we're going to release we're not going to release the tourniquets, okay? All right, we're not going to take the tourniquet off to do this part, okay? You can have them release their fists and relax for you. You're going to clean the site with our 70% isopropyl alcohol. We're going to use a circular motion starting from the inside out in concentric circles. That's important. When we go from the middle out 2 to 3 inches, we're going to allow the area to dry for 30 seconds to 1 minute until dry. This is so important. We don't fan the area. We don't touch it again. We don't blow on it. We don't let them blow on it. We don't touch it. We let it dry. We don't stick before it has dried because it is alcohol. It can lyse the cell. It can contaminate the specimen, and it stings. Okay? Let it air dry. Okay? It does not always take a whole 30 seconds. Okay? Don't dry the alcohol. It's not your job. Let it air dry. And don't touch the site after cleaning. That is what causes phlebitis. That's what causes issues. That is infection control issue. If you touch the site again, you're going to clean it again. That's when you should pop the tourniquet. If you got to clean it again, go ahead and pop your tourniquet. Okay? Give the arm a minute to rest. Put your tourniquet back on. Feel again. Clean again. And start over. Okay? It's okay. The patient will appreciate if you take your time a little bit, okay? So one thing you can do, remember I said pointing the corner of the alcohol pad as your marker? You're going to look for landmarks on their skin, a mole, a stretch mark, a vein, like a surface vein that you can see, something, a hair, anything on there to help you visualize where you're going to be inserting that needle at. You can also use the same gauze pad you use to clean the site to kind of give you like an X marks the spot, okay? So we're already going to have our equipment prepared, okay? It is okay to put together an ETS system. Now, if you get in there and you figure out you need a butterfly or a different system, you just pop the tourniquet and prepare that equipment. And then I come back and put my tourniquet back on, I feel again clean, and I'm ready to go, okay? Anchoring. You need to know the definition. It's using the non-dominant hand to anchor or secure firmly the vein. This is done by placing the thumb 1 to 2 inches below your intended site and pulling down towards the wrist. Now, if you are working on the hands, you're going to go above 1 to 2 inches above the intended site, okay? This is how we keep veins from rolling, okay? And this also allows smoother needle insertion. So we're going to hold the collection device with our dominant hand. Always bevel up. Bevel down is not going to be a good blood draw. It's going to hurt, and you're going to burst the cells. Bevel up. That's that slanted, pointed part up. And we will look at what that looks like. And then you insert it at a 30-degree angle or less. with smooth, steady forward motion. The quicker you go, the less it hurts, I promise, okay? When you go very slowly because you're nervous, you are torturing your patient. Just go quickly, okay? And we're going to work on that before we start sticking each other, okay? And we're going to go into how deep you go and really look at it this week in lab, okay? So when it says advance the collection tube into the holder until the stopper is completely penetrated by the needle, you're just popping the tube onto that needle, pushing back that rubber sleeve, okay? That's what happens. The rubber of the stopper pushes back the rubber sleeve, the multi-sample needle enters the tube, and your blood flows in, okay? You can have the patient release their fist at this time. I would not take your tourniquet off unless it's too long, okay? You're going to fill, remove, and mix the tubes immediately after. And my general rule of thumb for mixing is I gently mix all the way down until I set it on the table, grab the next tube or gauze, whatever is next in my procedure, okay? We're going to put our gauze, activate the safety, apply pressure. You're going to hold pressure there for at least 1 minute, because if you don't, you're helping a bruise to form or a hematoma. It's your job. It is the phlebotomist's job to make sure that patient has stopped bleeding before they get up from your chair, okay? We're going to talk a lot about this, okay? It is very important. We're going to discard the whole needle unit, transfer device, whatever we use. We're going to dispose of that in the sharps container if it's sharp. Labeling our tubes. We got to make sure the patient's first and last name is on there, their date of birth, the date and time of collection. This is what you put on the tube. Date and time of collection, your initials. I only put if they were non-fasting. I do not put if they were fasting. And then you're going to make sure you compare on each label tube with the patient's wristband and requisition. If I don't have, a requisition, if I'm just in a chair and I've got the tube and the patient and maybe the computer, I'm going to verify the computer. I'm going to tell the patient, is this you? And I'm going to show them every tube, okay? If they are alert, that is great to do, because this is what happens. If you use the same perfect technique with ID in a patient every time, when you're working in a place and there's a misidentification, you will know your steps and everybody will know that you always do it this way. And I'm telling you that because that has helped me when what will happen, and this should not happen, they'll leave their computer open because it's easier than everybody logging in to their own thing every time when you're in a busy place. And one person will be there, and so it'll be their initials on all the tubes. And then when a mistake happens, the person held responsible is that person that allowed their, login to be open and their initials going officially in the computer. And then people not labeling their tubes, and so with their initials on the tube. And then the one is screwed. But that if you're that one and they know that you always do it this way and they always hear you do it this way, asking the patient that, they'll know it's not you that made the mistake, typically. But we shouldn't be leaving our computers open, okay? In lab, we are going to be putting all of this information on there, okay? First and last name, date of birth. We don't have an ID number. Date and time of collection, your initials. We're not going to put this, but we are going to compare, okay? Always put your initials, date, and time on there. Now, observe any special handling instructions. We have a whole section about special collections that we're going to go into those things in depth, but just a little bit, like some specimens have to be put on ice. Some specimens have to be covered in foil to be protected from light, those kind of things, okay? We're going to make sure that our patient is good to go. We're going to dispose of our contaminated materials. 1 drop of blood is not contaminated. It's very rare that we have to use biohazard trash, okay? Everything goes, if it's not sharp, it goes in the regular trash. You need to thank your patient, remove your gloves, sanitize your hands, and then transport your specimen, whatever your facilities policy is where you're at, okay? All right, write down any questions you have, and I will chat with you all soon.